Hello, and thank you for attending today's webinar, Mastering Return to Work Timelines with ODG by MCG, the Ascend Method. Before we begin, just a few housekeeping items. All the webinar tools are resizable and movable. Expand the slides to full screen by using the arrows in the top right corner. If you have a question or need assistance, please message presenters and support. You can also access a detailed event help guide via the help icon. Lastly, this webinar is being recorded, and the recording will be sent to you within a few days. Once again, welcome to our webinar. Our presenters today are Dr. Leslie Cadet and Suzanne Swirsky. Dr. Cadet is the founder and CEO of Ascend Occupational Medicine Consulting. She is an accomplished Air Force veteran whose work as a flight surgeon aided in the successful execution of combat and airlift missions. After completing her military service, she earned a Master of Public Health and completed an occupational and environmental medicine residency. Now, as a board-certified occupational medicine physician in Southern California, she founded Ascend to help self-insured employers strengthen workers' compensation programs through expert medical oversight and by correcting missteps that keep claims open too long. With a team of physicians and claims specialists, Ascend identifies red flags, resolves stalled cases, and keeps treatment aligned with recovery timelines to reduce costs and expedite safe return to work. Suzanne Swirsky is a senior account executive at ODG by MCG. With more than 3 decades of experience spanning biotechnology, pharmaceuticals, regulatory affairs, and sales, Suzanne now serves as a senior account executive with ODG. For the past 15 years, she has partnered with organizations nationwide to improve disability and workers' compensation outcomes through evidence-based, data-driven support. Suzanne is passionate about helping clients apply evidence-based tools in practical ways that support better claimant outcomes and more efficient workflows. Thank you both for joining us, and I welcome you to begin your presentation.
Excellent. Thank you, Michaela. Good morning and good afternoon, everyone. We are thrilled to have you here. Welcome. This is officially the most highly registered webinar ODG has ever hosted, which tells us something important. Return to work guidelines are no longer a nice to have, they're a business critical priority. So let's start with a simple question, one we'll come back to throughout today's session. Do you have a clear shared way to tell when a claim is on track versus when it's quietly going off course? Most organizations don't have a medically grounded way to answer that, and it's often in that gap where claims begin to drift. What we know through ODG benchmarks and decades of outcomes data is that most common work-related injuries follow a recognized healing time course. The challenge isn't a lack of evidence, it's translating that evidence into early consistent action. That's where early intervention becomes critical, and one of the key tools that support it is the ODG risk assessment score. Believe it or not, 20% of claims account for 80% of costs. The ODG risk assessment score helps triage claims early by identifying risk, so higher risk claims can receive more hands-on management, a more experienced claims handler, or earlier clinical involvement, such as a nurse case manager. And the lower risk claims can continue efficiently through standard workflows. The next critical step is ensuring return to work expectations are clearly communicated and aligned. And that's where the ODG return to work prescription comes in. ODG has been publishing return to work guidelines since 1995. And in the early days, those guidelines largely stayed in hands of end users. The return to work prescription was created to help claims professionals and nurse case managers clearly communicate expectations to treating providers. It consolidates the diagnosis, job title or job class, relevant comorbidities, and job capabilities for both modified and regular duty. Once reviewed and signed by the treating provider, the return to work prescription is shared with the employer and the injured worker, so everyone is operating from the same set of expectations. And when injured workers know what to expect and have a clear return to work timeframe, outcomes improve and returns often occur closer to plan. Now, what makes all of this scalable is that ODG integrates directly into claims system through API-based workflows. Return to work timelines, risk assessment score insights, and return to work expectations aren't manual or disconnected. They're embedded directly into the claim. So with the push of a button, guideline-informed communications can be delivered consistently to providers, employers, and injured workers via email, fax, or text. That automation reduces friction, increases consistency, streamlines processes, and helps ensure expectations are delivered clearly across the life of a claim. So when you bring all of this together, ODG to define the expected timeline, the risk assessment score to identify risk, return to work prescription to align expectations, and integration and automation to deliver them consistently, you get better outcomes. And that's exactly what we'll explore today. I'm honored to be joined by Dr. Leslie Cadet, who will walk us through real-world examples of how this works in practice. Dr. Cadet, it's a pleasure. Welcome, and thank you for being here.
Thank you so much for the warm welcome, Suzanne, Michaela. Thank you, everyone who decided to give us a little bit of your time this morning. I'm really excited to be here. Today's session is going to be very practical. As Suzanne said, I'll be showing you exactly how Ascend uses ODG to turn timelines into clear, actionable conversations that keep claims moving, and so can you. For our objectives today, we will identify the recognized healing time course for the most common work-related injuries using ODG benchmarks. We will apply communication techniques that help set clear return-to-work expectations with treating providers, especially those who are not familiar with workers' compensation. And we will understand how timely return to work influences employer operations, claim costs, modified duty opportunities, and overall claim outcomes. Now, if I handed you a work comp claim today and I asked you a simple question, exactly when should this worker be back at work, what would you say? And I'm going to give you a moment to reflect on that. The worker fell off of scaffolding, fractured several bones, sustained a concussion. When should he be back at work? Now, most stakeholders cannot answer that with any level of certainty. And that single gap is quietly costing employers hundreds of thousands, if not millions of dollars every year. Now, even if you don't write the checks, think about it this way. When a hospital bed is occupied longer than it needs to be, it's not just a billing issue. That bed can't be used for the next patient. Staff time gets stretched, resources get tied up. And workers' compensation, prolonged disability works the same way. When claims stay open longer than medically necessary, it ties up adjuster time, provider schedules, employer resources, and system capacity. And that inefficiency eventually shows up as higher premiums, tighter utilization controls, more scrutiny, and more pressure on everyone in the system. So that's why this matters even if you're not the employer. The longer claims drift, the more pressure there is on everyone. And if you don't set a return to work destination, the claim will choose one for you. Now, today I'm going to show you how Ascend uses ODG to answer that question early, clearly, and consistently, and what that one shift does to change the entire trajectory of a claim. This is the same framework Ascend uses when we provide oversight for employers, what we share inside of our exchange community. And if you're not an employer, think about your role in the work comp ecosystem and how it impacts the employer as you interface with the worker. So for example, imagine your child stays home from school sick. You say, stay home until you feel better. And what usually happens? There's no clear endpoint. They rest a little, They watch TV, they check in occasionally, and before you know it, that one sick day quietly turns into several. Now imagine instead you say, you're staying home today, and tomorrow morning we're checking in to see if you're ready to go back, even if it's for a half day. Same child, same illness, completely different outcome. In workers' compensation, unclear return to work timelines work the exact same way. It's not about forcing anyone back. It's about setting a clear expectation so recovery doesn't become open-ended. Now, this is a 59-year-old stock clerk who was getting off of a pallet when a box fell, causing him to fall back and hit his head and elbow on the ground. ODG will look at the age of the worker, their job classification, any comorbidities or confounding factors, along with the diagnosis, and give you an idea of how long the injury should take to recover from. Now, how is ODG able to do that? They have millions of data points across 10 million claims that have allowed them to generate predictive patterns regarding disability duration. For a head contusion and an elbow contusion, and a person with the demographics I've described, ODG says that at best, it should take 7 days to recover, so looking under the capital B, and at max, 17 days, looking under the M. A stands for average. Now, this worker was originally seen at occupational medicine in August of 2024, treated successfully and discharged with no permanent disability or future medical care. The file was closed in October 2024, so 2 months. Claim drift was identified in May of 2025. So 6 months later, the employer notified the TPA that the worker was in need of additional care, noting that the worker said the pain returned 4 months earlier. So sometime in January or February of 2025, now adding on the neck, shoulder, and arm. There were concerns regarding the validity of the claim because of the timeline, but the worker's complaints led to referrals to orthopedics, specifically ortho spine, additional imaging, additional tests, then more referrals to pain management, ortho hand surgery for a carpal tunnel release. Now, because the claim stayed open well beyond the maximum estimated duration of disability, Ascend collaborated with the treating provider, equipping him with several key pieces of information. Number one, we educated him on the expected timeline of recovery per ODG. Number two, we provided him with film footage of the worker who stated he could not work as a stock clerk, but yet he was seen riding his bicycle, and not an e-bike, but a manual bike, and picking fruit from trees. Number three, we reminded the provider that if in his opinion, as he documented in the medical reports, was that the worker's symptoms were being caused by his prior non-industrial arthritis, it was okay to discharge the worker back to his primary care doctor for continued care of his non-work-related conditions. Now, this claim was open for a total of 464 days. This is more than 27 times the estimated disability duration. And it was on day 365 that the employer partnered with Ascend for assistance, and within roughly 3.5 months, the claim was closed. As we go through each of these case examples, and there are 4 of them, I want you to take note of how long the claims were open as compared to when Ascend intervened with ODG. The things that influence the closure rate are adjuster buy-in and their ability to secure necessary treatment authorizations quickly, physician and provider buy-in, their overall work comp knowledge, their ability to navigate the worker's emotions and coach the worker to play an active role in their own recovery, the doctor's willingness to focus on function over subjective complaints, their ability to perform disability management, and the worker's willingness to participate in the process. Lastly, the speed with which imaging and other ancillary services, specialty appointments are scheduled will also impact the closure rate. Now, had we not intervened, the worker would have gone to ortho hand and he would have received a carpal tunnel release. Mm-hmm. He would have gone to pain management to receive injections. And I want you to throw it in the chat. How much would those treatments, or in this case, non-industrial conditions, have cost? Well, in ODG, you can look up the cost of a carpal tunnel release for a person with the same demographics as our test case here. And the typical cost for a carpal tunnel release claim is $27,000, close to $28,000.
So Dr. Cadet, real quickly before we go on to the second use case here, initially that case seemed to be pretty easy with a low risk assessment score. So at what point in that case do you think earlier use of ODG expectations could have changed that trajectory?
I think the trajectory could have been changed the moment the worker came back the second time to resume treatment, going ahead and getting a new lay of the land in terms of what does ODG say it should take for this worker to get better, and having that as a foundation, having that as a goalpost of where should we be headed with this claim, I think would have been instrumental in changing the trajectory.
Right. Again, tying back to setting those expectations and communicating with the treating provider.
Exactly. So for our second case, it's a 39-year-old sales clerk who was going down a flight of stairs. He was carrying multiple empty totes. He couldn't see where he was going and slipped and fell on the last step, falling to the ground, fracturing his heel, which we also call the calcaneus. Now, for a calcaneal fracture, ODG says at best it should take 36 days to recover, and at max, 69 days. Now, the worker's calcaneus did heal uneventfully, but because of continued subjective complaints, the claim remained open for over a year. The podiatrist changed, and by a year and a half, the worker had new complaints that led to a diagnosis of plantar fasciitis by his new podiatrist. Now, because the claim stayed open well beyond the maximum estimated duration of disability, Ascend collaborated with the podiatrist, equipping her with several key pieces of information. Number one, we educated her on the expected timeline of recovery per ODG. Number two, we emphasized that the calcaneal fracture healed a long time ago, and that in workers' compensation, the focus is objective findings and function, not subjective complaints. We provided her with education regarding causation of plantar fasciitis, which is not known definitively because most of the studies have been cross-sectional, meaning they're taking a snapshot in time, showing us what happened at the moment of the study, not what happened first, not what happened in a series of events leading up to the incident that's being studied. Plantar fasciitis is a condition that's very common in the general population, and it's likely not related to his calcaneal fracture, as he didn't start to complain of plantar pain until almost 2 years after his injury occurred. We taught her about impairment ratings, apportionment, and future medical care within workers' compensation and what those things mean. So for those of you who aren't familiar, an impairment rating gives us a numerical value for a person's body part and the function of that body part. So in this case, his calcaneus is fully functional because the fracture has healed correctly. So there would be a 0% impairment rating. Apportionment splits up how much of a disability is due to a work injury versus not. We educated her that he's not disabled because of his work injury, and that any future medical care could go through his primary care doctor for his non-industrial plantar fasciitis. Now, this claim was open for a total of 689 days. It was on day 433 that the employer partnered with Ascend for assistance, and within roughly 8 months, the claim closed. Now, had we not intervened, the worker would have been treated for plantar fasciitis. He would have received injections, and he likely would have gone on to receive surgery for plantar fasciitis. How much do those treatments for non-industrial conditions cost? Well, in ODG, if you look up the typical cost of plantar fasciitis for a person with the same demographics, the typical cost is roughly $9,700. And I do want to say I see the comments and questions in the chat. I love it. Put all of that there, and near the end of the webinar, we will answer your questions. Okay. Claim 3, this is a 48-year-old supervisor who was pulling a bag of soup out of boiling water. The boiling water spilled and landed on her foot. For a second-degree burn, which means it goes through the first 2 layers of skin, but it doesn't go into the fat or the muscle layers, ODG says that at best, it should take 16 days to recover, and at max, 50 days. This worker was seen for multiple weeks. Her skin was healing, but she was not given work restrictions. And because of her past medical history of pre-diabetes, she was prescribed precautionary antibiotics to prevent infection. Because the claim stayed open well beyond the maximum estimated duration of disability, Ascend collaborated with the treating provider, equipping him with several key pieces of information. Number 1, we educated him on the expected timeline of recovery per ODG. Number 2, we shared that the worker has pre-diabetes, not diabetes, so infection concerns are not the same, and they are not an indication to keep the worker off work. We counseled him that the fastest way for the worker to recover is to participate in some form of light duty, even if it's sedentary. So this claim was open for 155 days. Ascend provided medical oversight from the beginning of the claim, and on day 60, once the maximum estimated disability duration had been breached, we intervened, and within 3 months, the claim was closed. Now, had we not intervened, the worker would have continued to not receive any work restrictions. The employer would have continued to pay out temporary disability payments. And this worker received approximately $1,100 every 2 weeks. Another month of disability payments would have cost roughly $2,300. Another 3 months would have cost roughly $7,000. So I want you to think of it like this. Imagine you're paying for a rental car while your car is in the shop. The rental costs about $1,000 or $1,100 every 2 weeks. If the repairs are done, but no one tells you your car is ready to go be picked up, you just keep paying for the rental. So 1 extra month, it's about $2,300 for a car you no longer need. 3 extra months, that's $7,000 for a rental that's sitting in the parking lot. So in work comp, temporary disability payments work the same way. If modified duty is available and the worker is medically safe to return with restrictions, but there's no clear work status issued, the employer keeps paying without getting the employee's productivity, their experience, their leadership back on the team. So this is a 50-year-old store clerk who was rolling up a tarp when unsecured rope became tangled around his foot, causing him to trip and fall when he took a step, straining his knee. For a knee strain in a patient with these demographics, ODG says that at best, in a 50-year-old, it should take 16 days to recover, and at max, 118 days. Now, The worker's knee pain did begin to improve as would be expected from a simple strain. The MRI of the knee, ordered in February, was not scheduled and performed until May. When the MRI was finally performed, it revealed severe osteoarthritis. Because the MRI showed diffuse severe osteoarthritis, which was not caused by a simple sprain, Ascend collaborated with the treating provider and the adjuster, equipping them with several key pieces of information. Number one, educating the provider on the expected timeline of recovery per ODG, emphasizing that the MRI findings were not industrial, encouraging the provider to discharge the worker back to his primary care doctor so that a total knee replacement could be pursued, and coaching the adjuster on how to position this to the worker. This was not an abandonment of care, but merely a transfer to the appropriate doctor. This claim was open for a total of 85 days. Ascend was also present at the beginning of this claim, and on day 15, when we noticed delays with MRI scheduling, we began to intervene. And within roughly 2.5 months, the claim was closed. Now, had we not intervened, it likely would have taken longer than 3 months to get the MRI scheduled, multiple weeks trying to get it scheduled, multiple weeks waiting for results. The worker would have been treated for severe osteoarthritis. He would have received injections. He would have gone on to receive a total knee replacement under workers' comp. And how much do those treatments cost for a non-industrial condition? Well, in ODG, the typical cost in this demographic for a total knee replacement claim is roughly $127,000. So ODG correctly identified the expected recovery window in every case. The claims didn't extend because the injuries were complex. They extended because the timelines weren't operationalized early and consistently. Now, not once did you hear me say the doctor started off with a timeline of recovery. There was an end goal in mind for closing the claim. Not once did you hear me say the claims team started off with a timeline of recovery, having an end goal in mind for closing the claim. Not once did you hear me say the ancillary services that control the timing of imaging appointments, physical therapy, etc., started off with a timeline of recovery, an end goal in mind for closing the claim. So the problem in each of these claims was not that the ODG timeline was wrong or unrealistic. The problem was claim drift. Now, return to work timelines aren't just clinical guidance, they're a management tool. And when timelines are clear, communicated, and reinforced, claims move to closure. When they're vague or ignored, disability quietly expands. Most organizations have access to ODG, and if you don't, this is a plug to please go get your ODG access. What organizations don't often have is a consistent process for translating these timelines into provider conversations, work status decisions, and expectation setting. And that gap between evidence and execution is where unnecessary costs and claim duration live. Now, some organizations address this by having an external clinical reviewer step in when claims start to drift. Others build internal capability by learning how to apply ODG timelines consistently across cases. At Ascend, we support both through our medical oversight programs and our exchange community, where we walk through real claims in real time using this exact framework to help teams intervene early and resolve drifting files faster. And as Suzanne and I start answering questions and hearing your thoughts and reading the comments, I'd encourage you to ask yourself, where do claims start drifting in your organization?
Excellent. Thank you, Dr. Cadet. And yeah, one thing that I consistently hear from clients is that having the guidelines isn't the issue. It's figuring out how to apply it consistently across claims. So what are your thoughts on how to improve this?
Well, I would recommend having an ODG review as a part of your standard operating procedures. So if you're a claims adjuster, when you're first receiving notification of the claim, do a quick ODG review and secure the timeline. And that's something that you can do while you're on hold to speak with the employer to gather the other routine pieces of information you would normally get. ODG is very user friendly. The other thing I would recommend is to create an ODG prescription if you're self-insured and share that with the doctors who are caring for your injured workers. A lot of physicians aren't even aware that the ODG prescription exists. If you're a doctor or a healthcare provider, talking about the timeline with your patient on visit number 1 and documenting that in your note is so important. I would say what's even more important is to revisit that timeline at every appointment to make sure that you're on target. Share the goal with the worker and get their buy-in.
That's one thing I encourage too. Communication and collaboration is everything.
Everything.
Yeah, excellent. So I do, for organizations listening that already have ODG, what's the biggest gap you see between access to the guidelines and actually closing claims faster?
The biggest gap that I see is sharing the information with the treating provider and then having the treating provider get it. I've worked for some organizations where the information was presented, but then for whatever reason, the doctor didn't execute upon it. So to me, that's the biggest gap, having the knowledge and then executing on it.
Excellent. All right, so I think we finished a little bit earlier than anticipated, but we do have a lot of questions.
Yes,
Excellent.
we have quite a few questions, so we'll try and get through as many as possible. If not, I'll send all these questions to both Suzanne and Dr. Cadet, and we can follow up after the webinar. Okay, so the first one is, what about mental health conditions? How do you ensure proper diagnosis? Do you ask standard scales in order to calculate estimated disability duration? What about if multiple diagnoses are combined?
Ooh, great question. So if you have a psych case, and let's say you're not a psychiatrist or a psychologist, so you're not sure what the diagnosis is, then you would wait until you get that first clinical note. And based on what the provider has put in the clinical note, now you'll go in and create your timeline. ODG is great in that you can put multiple diagnoses, multiple confounding factors, multiple comorbidities, and it will generate an accurate timeline based on those in those key inputs that you enter.
Correct. And we do have a proprietary algorithm that will automatically calculate the diagnosis that will take the longest to heal. So you don't have to worry about that.
Nice.
Perfect. I have identified many of these red flags you are speaking about, but my issue is getting RM buy-in where my concerns are ignored. Do you have any tips?
So for that individual, could I ask what is your, what role do you play in the work comp ecosystem? And while we figure that part out, I would say number one is having a conversation with the RN and trying to understand why your red flag concerns are being ignored and seeing if you can reach a common ground in that way. If you're a provider, we want to work in a collaborative circle, but ultimately, as the provider, you are the captain of the ship. And so it doesn't necessarily matter if the RN is ignoring your concerns because you have the power to move the claim forward as you would see fit. So depending on where you are in the ecosystem and what your job title is, that will kind of change how you would interface with the RN. So hopefully that helps.
Thank you. I've seen many cases where a work injury aggravated pre-existing conditions. How then do you determine objective versus subjective findings when a case seems to linger past ODG guidelines?
For me, I try my best to get prior medical records. And if I can get those prior medical records and it shows that there has not been an objective change in that pre-existing condition, then in my practice, I don't automatically blame the employer for something that has happened. I need to see some type of medical evidence that there's been worsening of the condition as a result of their employment. A lot of times patients will come in and they will say, well, it didn't hurt before this. And so I listen, I empathize, but I don't necessarily take that as the gospel for the reason why I'm going to let the claim continue on. I need to see some type of evidence that worsened the condition.
Great. And this is somewhat related, but how do you estimate return to work dates when they've exceeded ODG's original dates?
So I don't. I always come back to ODG. And so when I'm managing a case or reaching out to a provider, I always say, we are now 265 days beyond the estimated duration date. So I don't reset the goalpost. I point out that we are well beyond the goalpost and we need to get back on track. So I don't reset anything. I just try to hurry and get the claim closed, get the patient better, because we've gone off course.
Right.
Thank you. When an employee has an attorney, they will steer the patient to an applicant doctor who will keep them off as long as possible, sometimes up to 2 years. How do you handle applicant doctors?
So if I had to get in two different lanes, from the ascend standpoint, once the claim is litigated, we back off because we don't want there to be any perception that the employer is meddling with the case and trying to influence the doctor. When I'm seeing patients in clinic, I put everybody on an email chain and I just open up the communication. That's the applicant attorney, the defense attorney, the nurse case manager, the adjuster. Everybody is going to hear what I have to say because my concern is getting the worker better. So I don't really have time for the communication silos. So, sometimes the applicant attorneys will say to the nurse case manager, I don't want you to talk to my client. Well, that really impedes our ability to get the worker better. So I just try to open up the communication and put everybody on the same page.
Great. There's a lot of questions related to behavioral health and mental health. So what about emotional traumas? Have you had cases of severe depression in a worker who interviews traumatized clients regularly and whose psychiatrist says client is still having symptoms? What would you advise for case management in such situations?
Such a good question. Just about every worker that's had a severe injury has anxiety and depression. I think any of us would, because if you are the breadwinner for your family and now all of a sudden you can't do what you love to do, what you're passionate to do, you can't provide in the way that you once did, that's very depressing. So I always start by being empathic towards the patient and listening to what the concerns are. And even if they don't bring it up in the first visit, I bring it up. How are you doing? How are you processing everything that's happening? Number two, when I need to refer out to a psychiatrist or a psychologist, I will pick up the phone and I will talk to the provider and provide education around work comp, because most providers don't have any education on work comp. So I will say, my nurse, she was working on the floor. It was a traumatic brain injury patient. He wasn't in his right mind. He beat the worker up. And understandably, she does not want to go back to work. I have explained to her that I can keep her off of work for about 2 weeks, but then we need to reintegrate. And maybe it's not by going directly onto the floor where she was injured, but it's in some other area of the hospital. So, what I'm trying to do is educate the psychiatrist that just taking them completely off of work and putting them in the pajama abyss, that is not the way that we get the workers back to work quickly. So for me, it's really communicating with the other players involved so where the goals of care get aligned.
That's a good point. And also, one of the things that I love on the duration tab that we've put together for those that may not have that clinical background is collaborating for recovery. And so once an injured worker has gone past your, the B value, the best practice, they're approaching possibly hitting, going past the average time frame, that's definitely when someone can come in and take a look at questions that you can ask the treating provider to open that door of conversation. How much more treatment can we expect? What can the patient do in case that employer does offer any sort of modified duty? So we do have that there on the duration tab, which is very helpful. Even questions on the psychosocial factors that you can ask for the claimant. We saw a big uptick, after COVID with those psychosocial factors. And, unless you start having those conversations, you really don't know what's going on and what's delaying that recovery time. So all good stuff.
Great. How does ODG and Ascend help providers understand the difference between work-related and non-work-related, especially in cases that might involve pre-existing conditions, for example, lumbar disc herniations, especially when no pre-existing treatment has been undertaken?
So Suzanne, please piggyback on this one because from the Ascend perspective, we have to have a conversation with the doctor and present the reasons why we believe something is industrial or something is not industrial. So for us, it's having a conversation, providing education. Like the case with the podiatrist, she had no idea about delineating what's work-related versus not, because that's not the way we're trained. We're trained that whatever the worker comes or the patient comes in to tell you about, you deal with it. We're not taught to put things in separate piles depending on whether work caused it or not.
Yeah, that's kind of that's kind of a sticky situation, right? When you're dealing with a case like that. I would just suggest getting as much information as you possibly can with the background and history before determining and making any sort of suggestions on defining that timeline.
Because in ODG, the timeline doesn't change based on whether it's a work injury or not.
It doesn't know.
It's a universal application. So it really does come down to talking to the provider.
Perfect, thank you. How are we determining the anticipated MMI date?
Okay, so I will look and see, what was the date of injury? And then I will find my ODG timeline. And if ODG says it's 23 days, I will take 23 days, add that to the date of injury, and now that's my goalpost. So when I'm interacting with the treating provider, that's the date that I'm basing my recommendations on.
Great. And the M value can be used as a proxy for MMI within ODG, just so you have that measurement.
Yes.
Thank you. If you're in an urgent care setting, when would an injury be deemed out of scope? The concern would be, what if the provider believes nothing further can be done in our setting?
In my opinion, that can happen as early as the first visit. They come in. If you feel like you don't have the expertise to deal with whatever the ailment is and you feel it's out of scope, it's appropriate at that time to refer. If you feel like it's out of scope in terms of it's not a work injury, then just empathically, and I've probably said that word a billion times, but it is the key. Empathically explain that to the worker. We're not dismissing their concerns. We're saying, hey, I'm really sorry that you're not feeling well. Based on what you've shared with me, this sounds like something that was not caused by work. I know you started feeling the symptoms when you were sitting at your desk, but that doesn't necessarily mean that work is causing the sensation. And then you just explain. So you're still going to get the care that you need. It would just come through your primary care provider and not workers' compensation. And to be honest, sometimes I throw work comp under the bus. And I'm like, you would rather go to your primary care doctor because when she orders an MRI, you'll get it. If I order the MRI, you are providing critiques on why or why not you shouldn't get the MRI. So I just explain what we're doing and that they're not being abandoned. I'm just getting them to the right place.
Thank you. What is the best way to deal with migrating or changing diagnoses?
Copy URL and paste it into your claims note so that when anything changes in that claim, you can pick up right where you left off.
Exactly. And, I will tell the workers, when you first came in, you told me that it was your pinky toe that hurts. And now today you're telling me it's your shoulder that hurts. So I wish I was your primary care doctor because then I could deal with all those different body parts. But in workers' compensation, and you just have to rip the Band-Aid off. It does not work that way. You came in to tell me about your toe, and that's where the focus is going to stay, your toe. That's how I kind of deal with it. You're just redirecting.
Yeah, and diagnoses do change, throughout the life of a claim, and that's okay. You can still go back to ODG. Like I said, when you're using the web-based version, we do have the ability to copy the URL so that all of that information you've entered into the refine section is saved. And then you can add on, for instance, like if somebody has a back sprain and 3 months later, it's found that they have a bulged disc, may need surgery. You can open that back up, add the new diagnoses, and then also a surgery if that's the case, and take it from there.
Very good point. Very good point. And, sometimes there are other things going on in the background with the patient that's causing this migratory nature, right? And so if you've gone through and you've collected all of your objective evidence, your imaging, your nerve conduction studies, and you don't see anything wrong, there's a good chance that they have what's called a neural pain circuit, where the brain is sending out false alarms regarding pain when there's nothing structurally wrong. And so there's resources out there to deal with that type of pain appropriately. I don't think sending them from specialist to specialist to get, everything in the kitchen sink, I don't think that's wise. But you just want to make sure that you've ruled out any organic cause for migratory type symptoms.
Related to what Suzanne was saying about surgery, there's a question, if surgery is needed after initial ODG guidelines are created, why would we not reset the goalpost?
Well, you don't need to reset the goalpost. You're going to enter in the surgical procedure into ODG and then the date of surgery. Your return to work timeline expectations are automatically going to repopulate based on that date of surgery. So it will calculate from the date of surgery to the return to work timeframe.
Correct. And so there was an earlier question about, do I reset the timeline? And I'm like, no. So let me clean that up. Yes, if the person had surgery, as Suzanne said, I would go in and add that. And now it's going to give me a new maximum estimated duration date. And now that's what I'm going to use when I'm approaching the doctor about, hey, they had surgery 8 months ago. Things should be where they need to be by now.
Great.
Great question.
How can claim drifts negatively financially impact the occupational health clinics?
If I'm being 100% honest, I don't know that claim drift negatively financially impacts them, right? Because every time a patient comes into the clinic is going to get paid for that visit. So financially, I don't think there's anything wrong with letting the claim drift. And I've seen that a lot in the work that I do. Some providers, there's legitimate care that needs to occur, so the patient needs to keep coming in. But then there's other times where you're not doing anything that's really helping the patient. And so you just keep bringing them into clinic and nothing is happening and you're billing for it. I think where the drain on occupational medicine clinics comes in is a morale drain. Because if you're a provider in the audience, we've all had those patients where we can't find anything wrong and the patient keeps coming, or there may be certain behaviors that we would call red flags, and we don't see where they're truly injured, or they're unhappy with the way you're managing the case. So they bounce around amongst coworkers, and all of that is emotionally draining. So I think it's more of a psychological cost to off-med clinics more than it is a financial one.
Great. And someone wants to know, do you use independent medical examinations? If so, when do you use this tool in the process?
So Suzanne, I would say I personally don't use IMEs, but if you were going to get an IME, there would be nothing wrong with printing out the timeline and sharing that with them so that they have some schema of what your expectations were as the case was developing.
Oh, you're on mute, Suzanne.
Sorry about that. I was just saying, yeah, 100% spot on, Dr. Cadet. As I was mentioning earlier, in the collaborating for recovery section within the duration tab of ODG, we talk about when to bring in additional resources, right? You've approached that A value. You may have gone through the average and you're approaching that M, which is your proxy for MMI. Now's the time that you may want to consider those additional resources. Is it time for an IME, or do we need to look at voc rehab? But all of that is included within ODG's duration tab and collaborating for recovery, which is extremely helpful in guiding you through that timeline so that it doesn't become an outlier.
Mm-hmm.
How can ODG help once MMI is reached and the injured worker is treating under future medical?
Suzanne, what do you think?
So ODG doesn't really do MMI. Like I said, it's you can use the M value as a proxy for MMI, but that's, yeah.
Yeah.
We don't do permanent disability for adjusters when reserving costs. So we want to be more proactive.
And, once the worker has future medical care, they're allowed to continue treating. So I think the best use of ODG is at the very beginning when the claim first is born.
Great. I know we're almost at time, so we'll take a few more questions. If an injured worker is fired because of the injury, what is the motivation to get better from the injury, especially if they are receiving benefits from the claim that remains open since the providing doctor does not have a return to work date needed?
Michaela, I caught the first part. Can you just read it one more time for me, please?
Oh, yep, sorry. If an injured worker is fired because of the injury, what is the motivation to get better from the injury, especially if they are receiving benefits from the claim that remains open since the providing doctor does not have a return to work date needed?
I would say one of the motivations is yes, you're receiving benefits, but you're not receiving your full paycheck. And there's a certain level of self respect that's lost when we have to start relying on government assistance. So, for many workers, that's not the case. They are self motivated, they want to get back up on their feet, they are very much involved in their recovery. And so, those folks, they're self motivated. But for those who may need a little bit of a boost, I would say it's just you're not getting your full paycheck and you're not living out to your full potential by just saying, well, I'm going to throw my hands up and let somebody else take care of me.
How does the Ascend method's expected timeline strategy relate to post-concussion syndrome cases?
Oh, great question. Same philosophy. We would put the post-concussive syndrome into ODG. We would get our timeline and we would immediately start talking to the neurologist, the primary care doctor, and just getting everybody on the same page. So it's no different for a post-concussive syndrome than it is for any other diagnosis.
Great. Thank you, Dr. Cadet and Suzanne, for taking time to answer these questions. That's all the time we have left for today's presentation. For more information, you can reach out to your ODG account manager or sales executive. If you're new to ODG, you can reach out to us via phone or email. Don't forget to check out the related resources in the resource section of this webinar console. These resources and the webinar recording will be sent to you within a few days. Thank you again to Dr. Cadet and Suzanne for this great presentation. And thank you everyone for your great questions. Have a great rest of your day.
Bye. Thanks, everyone.
Thank you.